Hello, I'm Professor Stephanie Watson, and I'm pleased to present top tips for prescribing topical ophthalmic cyclosporin for Australian healthcare practitioners. Now, cyclosporin has roles in managing ocular inflammation. Firstly, it's an immunomodulator. Cyclosporin inhibits T-cell activation and downregulates inflammatory cytokines in the conjunctiva, leading to a reduction in inflammatory cells and markers on the ocular surface. Secondly, it's thought to increase goblet cell density and decrease epithelial cell apoptosis. This can further improve the health of the ocular surface. Lastly, it's thought to have roles in stimulating tear production via the sensory nerves in the cornea and the conjunctiva. In Australia, there are a couple of cyclosporin products available for topical ophthalmic use. Icurvis is the first cyclosporin to be PBS listed for ophthalmic use from the 1st of October 2021. Cequa was PBS listed from the 1st of June 2023, and Restasis, which is not yet TGA registered, but available via the Special Access Scheme and Authorised Prescriber Schemes. Lastly, cyclosporin can also be compounded. For PBS prescribing, this is done by ophthalmologists and therapeutically trained optometrists only. I'm now going to discuss the cyclosporin products that are available in Australia in more detail. And the first is Icurvis, which is a milky white cationic emulsion eye drop that's preservative-free. It's given once a day, typically at bedtime, and the current approval is for adults over 18 years for the treatment of dry eye and ocular surface inflammation in the setting of severe keratitis. And this is in patients who have not responded to treatment with tear substitutes. Cequa is an aqueous nanomicellar solution that's also preservative-free, but given one drop twice a day, typically 12 hours apart. It's approved for adults for treating keratitis with moderate to severe dry eye disease, again where prior artificial tear use has not been sufficient. Restasis is a sterile corn oil in water emulsion eye drop, given one drop twice daily. It's been approved by the FDA in the USA for the treatment of dry eye disease, which is inadequately controlled by artificial tears. The TGA has not registered Restasis, but it's available via the Special Access Scheme and Authorised Prescriber Scheme. It's indicated in exceptional circumstances where the prescribing clinician has first considered other appropriate treatment options. Lastly, compounded cyclosporin is available in an aqueous or oil solution with the oil either castor or coconut oil. It can be made preserved and unpreserved, and in a variety of concentrations, such as 0.02%, 0.05%, 0.2%, 0.5%, and rarely 2% and occasionally 1%. These higher concentrations, such as 1 and 2%, may not be tolerated well due to stinging and discomfort by the patients. Compounded cyclosporin can be considered in patients who are intolerant to the excipients or have had adverse reactions to PBS-listed products. There's limited pharmacies able to provide compounded cyclosporin. I'm now going to talk a little bit about the different formulations that topical cyclosporin is available in. First being the oil-based and aqueous formulations. Oil-based solvents that are used with topical cyclosporin are typically castor oil or corn oil, such as in Restasis. But in oil, cyclosporin has a low bioavailability to the targets on the ocular surface. There's also the increased potential for ocular side effects and poor tolerability. Patients can notice blurred vision, burning, stinging upon installation of the eye drop. Icurvis is a cationic emulsion, and it has less excipients it has a smaller particle size and increased bioavailability by being in this emulsion. The emulsion facilitates absorption of the topical cyclosporin to the ocular surface, enables greater optical transparency and a longer ocular surface time, which is why it's given once a day. This once a day dosage has increased patient convenience, which may improve compliance. It can also extend product supply and reduce cost. CEQUA is nanomicellar solution, and this favors the dispersion and solubility of the cyclosporin into the precorneal tear film, increasing the bioavailability of the cyclosporin and potentially reducing adverse events when it's in this nanomicellar solution than when it's not within the solution for 0.09% topical cyclosporin. Now, there are current PBS guidelines for Icovus and CEQUA, and these guidelines enable patients to access subsidized pricing. For the initial treatment, which is up to 180 days, patients to meet the PBS guidelines should have a corneal fluorescein staining score of grade 4 using the Oxford scale or equivalent, and an ocular surface disease score of 23 or greater. Their current disease has to be inadequately controlled with preservative-free artificial tears, and they have to be undergoing simultaneous treatment with artificial tears. So the topical cyclosporin can't be the sole therapy. So what does this look like? Well, when patients complete the Ocular Surface Disease Index questionnaire, this graph or figure here is used to determine the score, the grading of their dry eye disease. And if you look on the grade, a score of 23 is in this area here. And the score depends on the number of questions answered, which are between 1 and 12. And then you sum up all the scores, and this is how you get the final OSDI score. So it's moderate on the scale. In terms of ocular surface staining score, a score of 4, you can see on this grading scale diagram here towards the bottom. Now, if the patient is wishing to continue on Icovus after initial PBS script, the patient has to meet certain criteria. They have to have had an improvement in their corneal fluorescein staining score by 3 grades or more, and an improvement in their OSDI score by more than 30% from baseline. So for example, if the patient had a score of 23 at baseline, this would need to drop to 16 for the patient to qualify for the next continuing script of Icovus or CEQUA. Now, both Icovus and CEQUA can be provided on private scripts. And when a private script is written, the corneal fluorescein staining scores and ocular surface disease scores do not need to be provided. On the script, though, it's important to specify the dose and the number of repeats. So as I've mentioned, the dosage is once daily for Icovus and twice daily for CEQUA, and typically up to 5 repeats would be given. Explain to the patient when you give them a private script, though, that they won't be eligible for the PBS subsidy. Otherwise, their pharmacist is likely to ask them for an authority script, a PBS authority, and the patient will then come back to you and say, look, why couldn't I get the authority? And you can explain, well, the criteria for PBS subsidy weren't met. I was fortunate to put together a team of experts on ocular surface disease and dry eye from across Australia to come up with some practical guidelines for prescribing topical ophthalmic cyclosporin for Australian healthcare practitioners. And this was supported by an unrestricted grant from CSL Seqirus. Now, this guidance for everyday prescribing of cyclosporin is a series of top tips. So the first tip is prior to prescribing, Assess for symptoms and signs. That's mainly the ocular surface disease index will give you the symptoms, and the corneal fluorescein staining score, some signs. And this can help you determine the degree of the dry eye disease, well, the presence of it in the first place, and then a degree to determine if the patient might be suitable for topical cyclosporin, and then to determine if they would be PBS eligible. And when you follow the patient up, you can use these symptoms and signs to judge whether the patient is having an improvement with the treatment. Number 2, topical cyclosporin may be considered when dry eye symptoms and/or signs are not adequately controlled by frequent artificial tear monotherapy. 3, use commercially available cyclosporin products such as Icurvis, Sequa, and Restasis as per the Australian Therapeutic Goods Administration, TGA, product information. This will ensure an acceptable standard of quality with respect to efficacy, tolerability, and dosing schedules. And Restasis note is available via the TGA Special Access Scheme rather than on PBS scripts. Tip number 4 is that compounded cyclosporin can be considered if a higher concentration, e.g. 0.05%, 1%, or 2% is needed, such as if there is no response to a low dose or if there's sensitivity to excipients in commercial products. Number 5, use topical cyclosporin with preservative-free artificial tears, but do allow at least 5 and up to 15 minutes interval between the drops. That is between the topical cyclosporin and the artificial tear drop, in order not to rinse out the effect of the medication. Tip number 6. Currently available cyclosporin products, commercially available, are preservative-free. So each ampoule is intended for single use. The patient should be advised to discard the ampoule immediately after a single dose. Number 7. For patients to access PBS subsidized product pricing for initial treatment, that's the first 180 days of treatment for the available products, like Icurvis and Sequa, the patient should have an ocular surface disease index score of 23 or greater, a corneal staining score of at least grade 4 using the Oxford scale or equivalent, and inadequate control of their dry eye disease with monotherapy with a preservative-free artificial tear substitute, and concomitant treatment with a preservative-free artificial tear substitute. For a continuing PBS subsidized treatment, patients continue to need to meet criteria. And this is that they have already received a PBS initial treatment with topical cyclosporin, and that there's been an improvement in both ocular surface disease index score by 30% or greater from baseline. That's the score you gave in the initial application for PBS authority, and a corneal fluorescein staining improvement of 3 grades or more, measured using the same scale that you did at their initial assessment. The patient should be followed up at least every 6 months to assess treatment response, and you can provide further prescriptions at these visits if indicated. The maximum number of repeat prescriptions that can be provided on a single PBS script is 5, and this will fit with your 6-month follow-up schedule. Tip number 9, for a private prescription of topical cyclosporin, patients do not need to meet these PBS guidelines, but they should be advised that they'll not be able to access the PBS subsidy. Number 10 is to dose the topical cyclosporin as per the product information. For Icurvis, this is once daily, typically at bedtime, Sequa twice daily, and Restasis twice daily. Now, topical cyclosporin can also be used after low-potency topical corticosteroids, such as fluorometholone 0.1% or loteprodinol 0.5%. For the short term, generally, that's around 2 to 4 weeks. And this is in cases when there's been moderate to severe inflammation and ocular surface staining score of 4 or greater using the Oxford scale, such as in this diagram. Now, when you prescribe topical cyclosporin for ophthalmic use, it's important to counsel patients. And what you can say is that it can take between 4 and 12 weeks for a treatment response. If topical steroids are given, then the patient should be monitored closely due to risk of elevated intraocular pressure and cataract, because the topical steroids can be prone to raise pressure and induce cataract. Patients can be reassured that adverse effects are mostly mild and mainly relate to local reactions upon eye drop installation, including ocular stinging, irritation, blurred vision. Such adverse events usually don't require discontinuation of the treatment, but they may be more frequent with topical cyclosporin when it's in oil, such as Restasis or compounded cyclosporin, or at higher concentrations such as 1 and 2%. Remember to reassess response to treatment every 6 months. The SafeSight Dry Eye Registry can be used to monitor patients by tracking the dry eye disease symptoms. It can record the ocular surface disease index and help you calculate a score, and also monitor and record clinical signs such as corneal fluorescein staining using the Oxford scale or its equivalents. If you wish to join the registry, you can scan this QR code here or email us at the address below. Remember to tell your patients when you're prescribing topical cyclosporin that it may take at least a month to work, and further improvement can even occur up to a year. The stinging doesn't mean that the cyclosporin's not working and can often be relieved by preservative-free tears after a few times. Use the OSTI and corneal fluorescein staining to show your patient the treatment effects work. Now, with the SafeSight Dry Eye Registry, when you see the patient, a graph is produced, and this graph will summarize their treatment and their progress and can often be used to improve compliance. Patients should be advised to continue their lubricants. This is the SafeSight Dry Eye Registry graph for a patient. Then you can see that they have received at some point Icurvis here, which is the yellow-ish color on the treatment scale. And the tracking shows their response in terms of vision and symptoms and signs. Guidance number 14 is that topical cyclosporin may be considered for use in patients with dry disease associated with autoimmune disease, such as Sjogren's syndrome, related to ocular surface disease conditions such as trachoma, post-refractive surgery, LASIK post-cataract surgery, and other ocular surface diseases, including posterior blepharitis, ocular rosacea, graft versus host disease, allergic keratoconjunctivitis, and viral conjunctivitis, that is in patients with epidemic keratoconjunctivitis. But patients should be counseled that in these circumstances, the PBS subsidy does not apply. Treatment effect may take at least 12 weeks, and the evidence actually is limited on the safety and efficacy in these range of conditions. Now, number 15 is to remind you of some contraindications and cautions. So the use of topical cyclosporin for ophthalmic use has not satisfied the TGA categories A, B, C, D, and X for prescribing in pregnancy. The potential risk of prescribing cyclosporin during pregnancy or planning pregnancy or lactating is based primarily on preclinical evidence, and it should be weighed carefully against the expected benefit. Do not prescribe topical cyclosporin for patients with known hypersensitivity to the active substance or to any of the excipitants. Do not prescribe it for patients with active or suspected ocular or periocular infection, malignancies, or pre-malignant conditions. Topical cyclosporin A is neither TGA approved nor PBS listed for individuals under the age of 18 years. And topical cyclosporin as Restasis and Icurvis, though, have been listed as indicated as steroid-sparing agents for non-infective severe conjunctivitis for children over the age of 3 in the in-house medication resource called Med for Kids for use in the Sydney Children's Hospital Network. Remind patients not to use topical cyclosporin while wearing contact lenses. They should remove the contact lenses and wait 15 minutes prior to reinserting the lens after instilling cyclosporin. Cyclosporin is preservative-free, typically presented in ampules, and the patient should be advised not to touch the ampule tip to the eye or other surfaces to avoid potential eye injury and/or contamination. I'd like to close by thanking the SaveSite Registries team, and thank you all for listening.